and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hi, welcome to You and Your Doctor, where we're teaching you how to live a longer and healthier life. I'm Lorena Anderson, your host for this evening, and every Tuesday night we bring you this show where we help inform and educate you on the various doctors that are available in the South Florida area. So without any further ado, we are streaming right now on 1470 AM and 95.3 FM. And we're also on All County Healthcare Facebook fan page where we're streaming live, and AMP2 TV YouTube channel. So you can follow us there. Now, if you have any questions whatsoever for our doctors, please give us a call here at the station, 888-565-1470. We would love to answer any of the questions that you might have. Or you can also call All County Healthcare, which is a Medicare certified home health agency. The telephone number there is 888-717-7170. Ask for Maddie. She would love to help you with any of your questions or concerns. And or in case you did not get a chance to call in to either of our doctors this evening, you can also call Maddie. She can put you in touch with our doctors. So I'd love to welcome our doctors here tonight. We've got two of them that come to us together. They're both neurologists. However, their field happens to be quite different. So there's one that is particular in the Parkinsons and Alzheimer's. And then our other doctor, Dr. Costell, he is in the epileptic field, if I remember correctly. So welcome, doctors. Thank you so much for coming. And one of the reasons why we have you on together is that the two of you work together in the same practice. So it is a pleasure to have you. Please tell us a little bit about ourselves. Dr. Ferreira, tell us a little bit about where you had come from, what ignited this passion for you, how long you've been in the practice.
So I am originally from Florida, I guess.
A native.
Kind
okay,
of.
Great.
I went to high school here. I went to college here in Nova, medical school in Nova. Then I did a neurology residency at the University of Miami. And then I did a movement disorder specialty at Cleveland Clinic right here in Florida.
Oh, my goodness.
Which mostly specializes in Parkinson's.
Okay, that's what I was going to say.
Correct.
Movement disorder. I don't think I've heard of that particular terminology before.
Yeah, so mostly tremors, walking problems, Parkinson's.
I see.
And I've been together with Dr. Costell for 4 years. Yes, I think.
Okay, great. You had to double check there.
Yeah, I think so.
Well, I've got to tell you, what a great team these two make. They've been jabbering back and forth, and I've got to tell you, another wonderful thing is their sense of humor. I've got to tell you, the two of them have been just giggling the whole entire time. It's been wonderful listening to them. So, and tell us, Dr. Costell, what got you into this particular expertise, this practice?
Sure. Well, thanks for having us. I just wanted to tell you that.
Well, you're absolutely, well, thanks for coming in. We appreciate it.
So, as I am from New York.
Okay.
And I currently live, like us, in the 6th borough of New York, South Florida.
You're absolutely right.
So, right, we like hearing that, all the New York people out there like me.
Yeah. See, I told you, great sense of humor. Okay.
So, happy living here in the 6th borough of New York. So I grew up there, but I did do some traveling for my education. I wanted to sort of get out of New York for a little while. And so I did my college at the University of California in San Diego.
Oh, you did go the other, a complete different opposite coast, huh?
Sure. And then I traveled south, actually graduated from medical school in Puerto Rico. So
Wow, that's excellent.
And he speaks fluent Spanish.
Does he? Okay, well, that's always a plus.
Yeah.
sure, Dr. Ferreira and I, we both see patients in Spanish and English, so that's no problem.
Great.
Absolutely. And then, so then I went back to New York to finish my fellowship training, my extra training in epilepsy at NYU in New York City. And going back to New York was great and everything, but I soon realized, I still love New York, but it wasn't for me anymore. And so a great idea was to go to the sixth borough, South Florida.
I know exactly what you mean. I come from Chicago.
Okay.
It's beautiful in the summer.
Absolutely.
That's
Absolutely. I just got back from there. So,
Oh, great.
so now we're back to work. And yes, so I did my extra training again was in epilepsy, and I'm considered an epileptologist, a subspecialty in epilepsy. And that's what we do most of every day. We still see all kinds of patients, but that's where our passions lie. Dr. Ferreira in movement disorders and mine in epilepsy.
Excellent. Very interesting. Was there a particular individual or something that might have happened in your training or growing up that made you decide to go into epilepsy?
So when I was actually in medical school in Puerto Rico, as a third-year medical student, I think one of the first patients I ever saw in my student training class, the person had a seizure right in front of me.
Oh, my goodness.
And scary at the time.
Yeah, I was going to say, yes, it is a bit scary.
As a medical student, but I'd say years later, it was a great experience. And one thing led to another. That's where it really started, that you asked me. And I really did find a passion for it. And that passion continues to grow every day.
Oh, that's wonderful. And how about you? What made you decide to go into the movement disorder, Parkinson's, Alzheimer's?
Yeah, so that happened during my last year of residency. I realized that movement disorder is neat in that you can figure out what the patient has without any testing. You can figure out if the patient has Parkinson's or not based on their exam, on how they walk, on how they move.
Really?
So I like that part of it, that within one visit, you can really try to see what the patient has. So it's like instant gratification in terms of, can I diagnose this patient quickly enough? So that's why I liked it.
Do any of your patients come in and not really understand what is happening to them at that point?
A lot. I would say, most patients come in with non-specific symptoms. I've started walking differently. I'm falling a lot. My wife says I have a tremor, but they don't really realize until they come to the office and we examine them.
Wow. So there's no particular blood test or...
Not for Parkinson's.
Okay.
Yes.
How about for Alzheimer's? Because you also happen to be, that happens to be one of your specialties as well, correct?
It's one of our passions. We both see Alzheimer's patients just because of the community we work in. It's a geriatric community, so we see a lot of dementia. So we treat a lot of dementia. We even have some clinical trials on dementia. But there's no one testing, for example, for Alzheimer's, which is one type of dementia. Because there's different types of dementia.
Isn't there dementia like Alzheimer's is the umbrella?
No, dementia is the umbrella. Alzheimer's is just one part of that umbrella.
Okay.
And so there are some people that have a genetic type of Alzheimer's, but not everybody does.
Okay.
There is a special test that you can do for Alzheimer's. It's a picture of the brain.
Okay.
It's a PET scan of the brain, but it's not a blood test. And that can prove it. I think is a 98% accuracy.
So the PET scan Dr. Ferreira is talking about is it's known as an amyloid PET scan.
Okay.
This is what's called the most current biomarker. So the spots you see on the brain have this substance, a deposition called an amyloid.
Okay.
So the scan of the brain looks for these spots on the brain. So this is a test that we really want to have available to our patients. It is available to our patients under research investigation, which we do in our practice.
Oh, that's wonderful.
That test is available to those people but not to everybody, and maybe one day it will be.
Oh, okay. Okay. Well, that's really good to know. So, before we go any further, what I'd like to do is let our audience know. First of all, if you have any questions whatsoever for our doctors, you can give us a call here at 888-565-1470. We'd love to answer any of the questions that you might have. And how do they get a hold of you? I know that the two of you are in practice together, but how do they get a hold of you, and where are you located?
So we have two offices. One is in Delray, and the other one is in Boca.
Okay.
We are 4 practitioners. Dr. Costell and I are only 2 of 4.
Okay.
And you can make an appointment at the Delray or Boca office. And our number there is 561-482-1027. We also have a website. Our clinic is called Neurology Offices of South Florida.
Okay, great.
So the acronym is N as in Nancy, OSFL.net. And that's our website.
Okay. So thank you for going really slow, because sometimes, some of our audience members might be running to grab that piece of paper and pen so that they can write it down. And so I appreciate that. As we go along, because we get to spend the whole hour with you tonight. So as we go along, I'm going to be asking you again, just in case someone is really interested and they haven't had the opportunity of writing down that information. Okay. So I'd like to go into a discussion about epilepsy, because you're also saying that you're identifying working with Alzheimer's as well. Is there a correlation between the two, or are they separate entities?
So those two particular are considered separate diseases.
Okay.
Alzheimer's, dementia, and epilepsy. Let's see, risk factors. So dementia patients, some of dementia patients do develop epilepsy.
Oh.
So
and they'll have the seizures then.
they'll have
correct?
seizures. So
Okay.
certain patients with Alzheimer's dementia will develop seizures.
Mm-hmm.
So it's considered one of the not main symptoms of a dementia patient.
Mm-hmm.
But patients on the reverse of that, patients with epilepsy or seizures don't develop dementia as a symptom of epilepsy.
Okay.
They have they have some memory problems, and that's really more due to the medications they take rather than the disease itself.
I see. And how do they? How do you really diagnose it? Because there's various types of seizures that certain individuals can experience, but that doesn't necessarily mean it's epilepsy. How can you tell the difference, or what should the audience know about being able to understand the distinction between that?
Yeah. So by definition, if you're labeled epilepsy, it means you've had 2 or more seizures, clinical seizures. That is usually just a change in your behavior. So not everyone with seizures has what's called the grand mal seizures, where they're wiggling on the ground like a fish in the boat. Some people have what's called used to be called petit mal seizures, where they have they still have seizures, but actually they're really changing their behavior. They're not behaving appropriately, but they're not really shaking. If you have 2 or more seizures, whether you have the shaking kind or even the non-shaking kind, by definition, that's epilepsy. And no tests are really needed for that.
Okay.
We do testing to sometimes confirm when we're not sure. So patients come and talk to Dr. Ferreira and I say a lot of our visits are spent figuring out what's wrong with the patient. The patient won't come in and say, I just had 2 seizures and, I'm ready for my medication. So, they often come in and say that they blacked out or they fell out. They were found down. They had a car accident. And we have to be like a crime scene investigation and figure out, well, those were probably seizures. And so like for a patient I saw today. So there is a lot of investigational work done with us. I wish it was so easy to just give them the diagnosis the first visit, but often that's not the case.
Gotcha. Well, that's really interesting. Now, that's very informative, because a lot of times, they might not know or they might have had a little bit too much to drink, or do you ever find any kind of correlation in that? Where, I know that some alcoholics can go through the blackout. Did you see any correlation in that, or?
It's a great question. So, I was being light with the term to say 2 more seizures equals epilepsy. It's a little more involved with that. If you have you have to have 2 or more unprovoked seizures. Unprovoked really means you didn't cause the seizure upon yourself.
Oh, okay.
For instance, alcohol wasn't involved.
Okay.
Sleep deprivation wasn't involved. Any toxic substances weren't involved.
Mm-hmm.
So there's no real culprit there. The culprit is just your brain.
Gotcha.
So alcoholic seizures are not considered a part of epilepsy.
Very good. Thank you for that. Thank you. Because I would think, that the public might need to have that type of information because, we are called, there are some individuals that, can overindulge, end up passing out or having a blackout, not remembering, and begin to wonder whether or not that has anything to do with it.
Absolutely. Yeah. So alcoholics do black out a lot, and some of them do have seizures, both in the intoxicated state and in the withdrawal state. But in either case, when alcohol or any toxic substances are involved, particularly amphetamine medications, then those are considered provoked seizures or convulsions, and those patients are not diagnosed with epilepsy.
Okay. Thank you for that. Thank you. And Dr. Ferreira, when you are first interviewing a possible Parkinson's patient, what are some of the other things that you end up looking for? Or some of the indications that they might be running into a serious problem?
So it's usually changing gait or changing walking. Are they slower than usual? Have they had any falls? And I also go over some of the what we call non-motor symptoms of Parkinson's. So everybody knows the motor symptoms of Parkinson's. They always heard of tremors. So everybody that comes to the office, if they have a tremor, they always ask, do I have Parkinson's?
Wow.
And most of the time it's not, especially for the young patients. But there are other what we call non-motor symptoms. There are symptoms that are very non-specific, such as long-time depression, history with insomnia or problem sleeping, constipations, erectile dysfunction for men, urinary incontinence for women, something called REM behavior disorder, where these people have very vivid dreams and they act out their dreams at night. They punch their partner, they scream, they kick. And so those are what we call non-motor symptoms of Parkinson's. Wow. And those are clues that tell me that perhaps the patient most likely has what we call a neurodegenerative disease, such as Parkinson. Degeneration simply means that as time passes by, the brain degenerates. And so that specifically the REM behavior disorder gives us a clue that perhaps the patient has Parkinson's.
Well, I have got to tell you, that's so interesting. And I love the fact that you really sit down, you listen to the patient, and then you very scientifically go through the questions and answers looking for any kind of information. I've got to tell you, this is one of the reasons why I'm so grateful to All County Healthcare for providing this show for us, because first of all, it helps inform and educate us. But the other thing is that we get to have doctors here, experts in the field, that have the most beautiful and compassionate bedside manner. And I've got to tell you, especially when it comes to this, and there's no real test to be able to figure out if these individuals are dealing with a particular disorder or disease, that those, as you said, it's almost as if you're at a crime scene, and really taking a look to make sure and do the investigation, and that is absolutely wonderful.
I do want to correct something, though.
Yes, please.
In terms of Parkinson's, so we don't need a test for Parkinson's, and still. the way to diagnose Parkinson's is with what we call a clinical diagnosis. So a doctor sees you, examines you, and he thinks he has Parkinson's. So till today, that's how you diagnose Parkinson's. However, there is a special, again, a PET scan of the brain that looks like the dopamine neurotransmitters of the brain.
Wow.
And if you have some confusion, you can order this test to see if the tremor is from Parkinson's or for something like essential tremor. So you can order this test. Most insurances do not cover the test. Okay, it's called a DAT scan, D-A-T, like DAT.
Okay.
And so we can order the test. I think Medicare may help cover some of it, but most insurances don't cover for it. So there is this extra test. If the doctor's confused or the patient really wants to know, then you can order this DAT scan. But in reality, it's a clinical diagnosis, and any neurologist should be able to diagnose Parkinson's without the test.
Well, that's really, really interesting. Thank you. Yes, absolutely. But that's good to know. Go ahead, doctor.
So as specialists, epilepsy and Dr. Ferreira, movement disorders, we'll often send patients from other, even other neurologists when, like Dr. Ferreira was saying, a general neurologist should be able to diagnose a lot of these illnesses and do at least preliminary testing and treatment. When the patients are not doing well, a lot of times we're sent to patients for other options, and that sometimes consists of changing their medicines, but it's often for surgical options. So it's not like we're neurosurgeons, but we work a lot with neurosurgeons for surgical options for both epilepsy and movement disorders. There are medical options and surgical options.
That's very interesting. So you not only can work with these various disorders and everything with medication, but then there's also the surgical options as well that's open to them. Does insurance cover the surgical options?
So insurance companies do thankfully enough cover these surgeries.
Great.
They're costly, but they are covered for the most part. So that's in favor of the patient.
That's wonderful.
Absolutely.
That is wonderful. So now the both of you have been together for 4 years and practicing together. What do you see? I think that one of the things that you said that I was picking up on a state-of-the-art thing was that particular VAT.
The one for Parkinson's?
Yes.
The DAT scan.
DAT scan,
Yes,
not
yes.
the VAT, the DAT scan. Okay, so that's one of the things that are up and coming state-of-the-art.
Correct.
To help. Okay, great. What other state-of-the-art inventions, I guess you could call it, that are coming up, techniques that are coming up that you see that is really changing the face of the diagnosis?
For epilepsy, it's, I think, even more challenging, and I can say that as an epileptologist, because the patient in the office usually feels fine.
Right.
So I'm actually trying to get information from something that may have happened yesterday, a week ago, a month ago. So often there is a big challenge there, not being there at the moment. So what we try to do is get monitoring on the patient, almost like what a cardiologist would do to monitor the heart. They can do prolonged monitoring. So we're getting better at doing these prolonged monitorings. We just started sending actually these monitoring devices to patients' homes. And they can now be monitored, believe it or not, on camera.
Wow.
Just like today.
At home for 72 hours. They can be monitored and watched. It monitors actually their heart rhythm and their brain rhythms. And that's something very new that we just started doing. So
that's wonderful.
Absolutely.
That is great.
Yeah.
Yeah, I know. I'm thrilled. That sounds really incredible. Now that they've started, allowing that type of recognizance to be, put in there where they can be watching for 72 hours to see whether or not there's any kind of a seizure that happens.
Correct.
Wow.
And I just learned today that you can do it 5 days, or I think the most is 7 days.
Yeah, so you can monitor these patients the longer you monitor somebody, the better.
Yes, yes.
And my esteemed colleagues have had somewhat advantage of having even implantable monitors or external monitors for weeks, months, or even years. And our challenge in the past has just been maybe in the office we do those testings for an hour, 2 hours. At home we were doing them for about 24 hours. So now we started doing for 72 hours. We've had to usually hospitalize patients for that kind of monitoring. So it's really wonderful that we can offer these services for patients.
Yes.
And so that technique is wonderful. There's surgical techniques out there, even that you can monitor within the brain. You can actually
Really?
put a recorder on top of the brain, and that would be done by neurosurgical. And that is something that you can do extensive monitoring with. And that's fairly new within the last year or two. That's a procedure called NeuroPace.
Okay.
Or RNS.
Okay.
RNS or NeuroPace actually can put a monitor inside the brain, and we can monitor patients basically indefinite.
That is fabulous. That so I'm so fascinated with the medical field because they're making so many changes, and the level of education that a lot of you are getting is just absolutely I'm so excited. I'm so excited.
It's pretty cool stuff.
It's so cool. It's so cool. Yeah.
When we both started training, actually me a little early and Dr. Ferreira, neurology was always an interesting field for me and others, but it was, to be honest, a frustrating field up until a few years ago.
Really?
Very challenging for treatment options. We were always pretty good at diagnosing patients. We're pretty bright individuals so the diagnosis has mostly been there, but the treatment options were very limited up until a few years ago. So there are several diseases, including the ones we're discussing here, that have really made a lot of strides in treatment options. And so the field of neuroscience and neurology, it's not as frustrating it once was. We're no longer considered as the doctors that really can diagnose but not treat.
Oh, well, that's really that's phenomenal. I'm thrilled to hear that, and there's no stopping it either.
No.
That's what I'm really excited about. I mean, the advances that you've seen within these last 2 years are going to be nothing in comparison to the next 2 years, and the 2 years after that.
Correct.
That is exciting.
Yes.
That is absolutely wonderful.
And one of the diseases that we both kind of treat is the Alzheimer's that you had mentioned, because, as you know, when your patients are diagnosed when they're 65 or older usually, and we really are trying to make strides in that. That's like our current, barrier we're really trying to get over. There's a lot of clinical research money being put forth in all of neuroscience, but there's a big push right now with Alzheimer's, with the baby boomers that are basically going to be, getting up there in age.
And something, and we're going to discuss that in our next half hour.
Okay.
Because you're right, that is huge. And there is, as you said, dementia is the umbrella, and then there's various type of Alzheimer's that is being, that people are being affected by. So we're going to take a commercial break here. Stay tuned, don't leave, we'll be back, and we'll be discussing Alzheimer's next.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
Getting older is not for sissies. That's what one of my patients says. And it's funny, but it's true. Live long enough and you'll get arthritis, skin cancer, probably one of the common chronic diseases like CHF, COPD, diabetes. At All County Healthcare, we teach you how to manage your disease. We make sure you know how to take your medications and how to recognize signs and symptoms before requiring hospitalization, no matter how many visits it takes. You didn't move to Florida to be sick. You moved here to enjoy the rest of your life. And that's exactly what our team of nurses, therapists, and aides at All County Healthcare help you do.
You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Hi, welcome back. Thanks for sticking with us. If you have any questions whatsoever, please just give us a call here at the station. The telephone number is 888-565-1470. I'm Lorena Anderson, and I am your host for this evening. And we're being presented by AMP2 TV and proudly sponsored by All County Healthcare, who are a Medicare certified home health agency, where patients are the heart of their business. And we want to continue our discussion with Dr. Ferreira and Dr. Costell about Alzheimer's, because that happens to be one of the areas that is of main concern, especially down here in South Florida, with the baby boomers and such. So what are you seeing in terms of that? I mean, we were talking first about the dementia, and then that happened to be the umbrella. And then you said that there's many different types of Alzheimer's that are underneath that umbrella. Please share with us. So educate us.
So there's different types of dementia.
Okay, different.
Yeah, so dementia is simply a memory disorder that is affecting your activities of daily living. You know, you forget how to turn on the car, you forget how to turn on the microwave or use the remote control. So that's what dementia is, but there's different types.
Okay.
So Alzheimer's is the most common one in the US, but there's also something called vascular dementia, and that's when people have so many strokes in their brain or little strokes, and that affects their ability to think well.
Okay.
And then there's something called Lewy body dementia or Parkinson's dementia. That's a dementia mostly related to Parkinson's. A lot of people will know that, for example, Robin Williams had it. So that's why I try to tell people there is this other type of dementia. So Alzheimer's is the most common, vascular is the second, Lewy body is the third. And then there's others like frontotemporal dementia, alcohol-related dementia. We can go on and on. So just remember, dementia is just a disorder of memory.
Okay.
And then Alzheimer is the most common type of dementia in the United States.
Okay. And that can attack, that's just not memory, is that correct? That can attack other areas in the frontal lobe. Sometimes it attacks the language. Share with us more about that, please.
Yes, so the disorder, unfortunately, is becoming more common as we're getting older. So there's over 5 million patients that are currently diagnosed with Alzheimer's in this country.
Oh, my goodness.
And so 1 in 9 people age 65 and older are diagnosed. It's a very, very prevalent disorder. So
now, you were kind of saying that was in America. Is it global?
So of course, it's a worldwide illness.
Okay.
We don't have worldwide statistics, but globally, it's a huge problem and a huge cost burden, as we know, taking care of these folks.
Yeah.
You know, so the disorder definitely clinically causes not only memory cognitive issues, but personality problems, walking problems, a lot of things that people were once able to do, even more than their activities of living, which are standard questions, cooking, bathing, driving, but it does affect them in a lot of other ways. So these patients often, of course, at later stages, sometimes we catch them earlier. There are 3 stages, really: early, middle, and late of Alzheimer's. So really early, middle, and late stages. And towards the later stages, these patients need a lot of assistance. Alzheimers.org or alz.org is a website I would refer people to.
Oh, great. Thank
that
you.
Talks
Yes.
a lot about the illness, and it talks a lot. You put in your zip code, and it's going to give you a lot of support groups.
Oh, super.
Yeah, and so
Give it one more time for our audience to be
Yeah.
able to write that down.
the easier one is www.alz.org
Okay.
or alzheimers.org.
Okay, great.
If you go to that website, it's going to give you a list of a lot of resources, both education and caregiver support groups. These are really valuable for patients and their caregivers.
I have somebody who's quite close to me and was diagnosed with early onset Alzheimer's. She was 52 when she was diagnosed with it. And I've heard also that it takes a couple of years before they really can diagnose. Is that correct?
So I have to say that clinically, meaning when the patient goes to the doctor and we do special memory testing with a neuropsychologist, it can take time to diagnose. But remember that special PET scan that we were talking about in the very beginning called the AMIVIB PET scan is an amyloid PET scan.
Yes.
So that can be positive 10 to 20 years before you get Alzheimer's.
Wow.
The problem is that not everybody that has this positive PET scan will get Alzheimer's. So that they don't order it just because.
Yeah,
because
well,
a
I
lot
might
of people
get
will
scared.
get it. Correct. Some people
Yes.
will get it positive and then they may not even experience the symptoms. But I believe it's 80 to 90% accurate, this PET scan.
Wow.
So you can see the plaques 10 to 20 years before.
That is, yeah, I can see why somebody might not want one of those because it's kind of like then you're sitting there on the edge of your table because what are you going to do? So you find
Correct.
out,
And then
what?
we don't know how to stop it yet.
Yeah. So I can understand why some people wouldn't want to have that knowledge.
Patients often ask us, is there any way to stop it? Like Ferreira said, there are a lot of investigational studies looking at vaccinating people that are mostly without symptoms. So they have like family history of Alzheimer's. And
Does it go down generation from generation? Does it skip a generation, or how does that work?
we haven't found, there's a lot of theories on if there is a genetic component to Alzheimer's, right?
So there are some type of Alzheimer's that are genetic, but not all. So there's the patients with the preselin positive chromosome, the ApoE chromosome. It kind of, that one just predisposes you to Parkinson's. So there are some genes that put you at higher risk of having Parkinson's.
Oh, okay.
So we know those genes. But again, just because you have a gene doesn't mean that you will get it. But those are the type of people that we are putting in our current research trials. The patients that have these positive genes, that have the positive PET scan. But again, not everybody with Alzheimer's has those genes. So
Yeah, well, that's what makes this so intriguing, shall we say, because there are so many variations. How do they get a hold of you in case you're looking for people to be on that research program with you?
is our just office number,
Okay.
which is 561-482-1027.
Okay.
We have one current research trial in Alzheimer, but there are many others. And even if we don't have that research trial, we can tell the patients where to go depending on if they qualify or not.
Oh, excellent.
And we have other research studies going on with Parkinson's and migraines and multiple sclerosis.
Wow.
We're very, very active in terms of research.
Excellent. Oh, that's wonderful because that's what we do need. We need more research in order to understand these
Correct.
various diseases.
Correct.
Current theory is we're realistically about 5 years away from finding the next generation therapy for a real treatment for Alzheimer's.
Really?
Our current medications really mitigate the symptoms, and this is something I discuss every day with patients. So we can really improve how you feel and how you function, based on these like daily living scores. We can probably get the patient to just feel better and do a little better, but that window closes sooner than later. So we're really not doing anything to mitigate the disease.
Okay.
And those are called disease-modifying therapies. We have those for a lot of diseases like MS, multiple sclerosis. We don't have those for Alzheimer's, but we're researching. We're researching whether either vaccinate patients, and the other trials are looking at the PET scans, and really what we can do to break up these amyloid plaques.
Oh my goodness. Okay, great, great.
Sure.
That's all wonderful, wonderful technologies that are coming into our view. So, and it's because of your research. So, thank you very much. Where are you seeing the average age of Alzheimer's coming in?
So the official age of onset is 65 and older.
Okay.
We tend to see some patients a little older than that. So even though that's the diagnosis, the average age I see is about 75 in the
Okay.
practice because of South Florida, our geriatric population. But officially, you're diagnosed. You have to be 65 or older to have the diagnosis.
Gotcha. Okay. And because I do know that my one dear friend, was diagnosed at 52, and she's still with us. However, in the later stages now. So we've, understood the walking difficulties. Speech has been gone for at least 4 years now, 3 to 4 years, and some of the other, difficulties that we've seen. So I'm familiar. I was just wondering whether or not you're seeing any kind of population that's getting it younger and younger.
Oh, we do see it. They're rare.
Okay.
Just because of, like Dr. Costell said, where we are.
Okay. Yeah, we're in South Florida.
Correct. But there is young...
The 6 boroughs, right?
Yeah, yeah. So there is young onset Alzheimer's, which your friend had. But we mostly see the 70, 80-year-old patients.
Okay.
Let me
Alrighty.
comment on that. When we see
Sure.
these, what's called neurodegenerative disorders, movement disorders, and dementias at a young age, the younger you get, the more we believe there may be a genetic component
Okay.
to it. So,
that's interesting.
yeah, so there's probably a correlation with having genetics and having younger onset illnesses, neurodegenerative illnesses, just as a whole.
I see.
So an extremely young patient, there's a very good chance there's a gene. The very geriatric patient, there's a much less likely chance. So that's something that's asked to us a lot. My grandfather, in their 90s were diagnosed with this. What are my chances? The good news is, for you, not too much. The bad news is, that they have this illness.
Okay. Okay. Well, that's good news. That's good to know, because that can at least give them a prelude to maybe some of the tests that they might want to take just to make sure.
Correct.
Excellent.
Absolutely.
Excellent. I'm going to, go back to another one of our discussions that we were having before with the epilepsy. Is there a particular age that you see that at?
There's childhood epilepsies, which I am qualified to see, by the way. I can
okay.
see anyone alive with epilepsy.
Okay.
My training was both in pediatrics and adults.
Excellent.
So I do focus more on adults. Just because, again, where we live. So the average age for me, there is no average age of epilepsy for adults. I'd say I see younger patients than older patients, but I see patients of all ages with epilepsy. There's not like this sort of magic age group that gets epilepsy.
Okay. Well, that's kind of what I was, getting at, saying whether or not there's something that had... there's something that's happening, where at a particular age, all of a sudden it comes alive. What about with the MS? Because I know that you've been working in that field
Yes.
as well.
So MS, the usual MS patient is a young female in her 30s.
Really?
But there is young onset MS. Also, you can see teenagers with MS. but usually is a female in her 20s or 30s. Although men can also get MS. And Caucasian. So Caucasian female in her 30s.
Wow.
But African Americans can get MS. Older patients. I had she was 60-year-old, and I just had diagnosed her with MS. So you can see all range of ages, but the average is 30-year-olds for MS. And for Parkinson's, it's about 62, the average.
Okay,
But
that's
again,
good
you can see
information.
young onset Parkinson's, just like you can see young onset MS and young onset Alzheimer's.
For Alzheimer's, being Hispanic or African American puts you at more risk for Alzheimer's than being Caucasian. A slightly higher risk, absolutely.
Wow. And there's no rhyme or reason for that, or it's just...
Those are statistical numbers.
Okay.
Meaning there's no, genetic component we can find more in African Americans or Hispanic backgrounds. We haven't at least located the genes at this point. There may be. These are just known risk factors. Your race is a risk factor.
Okay.
Correct.
All righty. Now, is there anything, you said the 30-year-old female Caucasian. Is there anything that set you up for that? Is there, I don't know, genetic? Is it something that they might be doing in their life that, can cause that? Is there any correlation whatsoever with their lifestyle?
So for MS, we're talking about multiple sclerosis.
Yes.
It has to do with the latitude. I believe that's the word. The latitude in which you were born. So if, for example, if you were born in the Caribbean, you have a lower risk of getting multiple sclerosis. But if you were born in Europe or New York or Canada, you have a higher risk of getting multiple sclerosis. So they believe is probably, and this is just theories, because in reality we don't really know 100% what causes MS. Although there are some genes that do predispose you to MS, and the possibility of maybe getting a virus when you were younger, a virus such as mono, can trigger something in your immune system when you're young, and usually is before the age of 12. That may predispose you to getting MS when you're a little older. So, but all these things are not 100%.
Yeah, well, I don't think anything is 100%, to be honest with you.
But that's a theory. That latitude and maybe some virus.
So it's like the environment, or maybe the climate.
Correct. We don't know.
The history with the MS is, so they notice populations, the farther away from the equator you get. Farther away from the equator, the most northern hemispheres and the most southern hemispheres, they've just found historically there are more cases, but because of so much movement in the world now, that sort of dwindled down. So we don't always just say because you are like from these parts, you're. But historically, patients have come from like Norwegian countries, or even very like South American countries. Yeah, that's so. The farther away from the equator. Puts you somewhat more at risk.
That's very interesting.
Yes.
Yeah, but we are becoming more global now, and we're moving, more. It's not as, like 50 years ago, 60 years ago, where you just stayed in that same community that you grew up in and lived the rest of your life in that community.
We used to call them vitamin D deficient countries. These northern, and that's actually why even till today we tell every single MS patient to load up on vitamin D. As in dog. Absolutely high doses of vitamin D.
That is very good information. But please make sure you go to your doctor to get that information, or be able to know how much, because can't you get vitamin D
toxicity?
Yes, that's what I thought.
So you should always, before taking vitamin D, probably talk to your doctor.
Yes.
And ask which dose is good for you, because you can get toxic on vitamin D, and you don't want that.
Yeah. And or what, 20 minutes a day out in the sunlight.
Correct.
Yeah, I'm all for that.
Yes.
That's why I moved from Chicago down here. I would go through it's the SAD syndrome, I think it's called, where all of a sudden, like today, I would be in total depression if I was still up in Chicago.
Yes.
So I understand that.
So
Yes.
these MS patients should have vitamin D. It's interesting though. Too much of anything, including being overheated, MS patients, the disease doesn't get worse, but they certainly feel worse when their bodies are overheated. So actually, a lot of MS patients feel terrible when they're in saunas and jacuzzis. Their symptoms seem to come out, but the disease again doesn't get worse. And when they cool off, they actually feel better.
Oh, well, that's good to know.
Yeah.
Excellent. Excellent. What are some of the symptoms for MS then as well, please?
You want to talk
Either.
about that?
So they're very non-specific neurological symptoms because MS attacks your central nervous system. So that includes your brain and your spinal cord. So you can get any symptom that has to do with your brain and spinal cord. So you can only imagine. So you can get either numbness of one part of the body or weakness of one part of the body. So it's usually they'll present, it'll be a young patient that looks like they're having a stroke. Right, so they'll get weakness of part of the body. They may get numbness, and so those are the symptoms. So it almost mimics a stroke, but for the most part, these patients are younger.
Okay. Okay, great.
Yes, and they can get problems walking, problems with memory. So as MS goes on, they can get the symptoms just accumulate.
Okay.
And the good thing about MS is that over the past 7 years or so, there are what we call disease-modifying medications. So there are plenty of MS drugs that can actually slow down the progression of MS, which we cannot say for Parkinson's, we cannot say for Alzheimer's, but they are disease-modifying medications for MS. There's so many. So there's no reason for any MS patient nowadays to end up in the wheelchair because there are so many drugs.
That is absolutely amazing.
Do you agree? Yeah.
That's such...
So, yeah.
That's exciting information, that it's not a death sentence.
Not anymore.
Wow.
And there's still research going on. For example, we're doing a research in MS currently, comparing one oral drug and one injectable drug. And again, both drugs are disease-modifying drugs. These medications are slowing the progression of MS in the brain. And so, great time in the history of neurology right now.
Oh, my goodness.
Because we can slow down these diseases.
Yeah, one of our next challenges, one of our next breakthroughs will be migraine headaches.
Oh, my gosh, really?
Yeah, so I mean, we both are specialists, but I'm going to tell you, we spend a good majority treating headache patients, migraine. And by next year, we hear that there's going to be a breakthrough medication for migraine.
Oh, my God, that's fabulous.
Correct.
That is absolutely fabulous because you're right. There's so many that are dealing with that, and they're down for the count, and they cannot function at all. And it's just it's paralyzing.
Correct. Yes.
Oh my goodness!
Right now we have a lot of great therapies. So I'm not saying today, as of today, Dr. Ferreira and I and our other practitioners are doing wonderful, and we're going to do even better next year.
I love that. Oh, that's exciting news. Because I know of quite a few people that have had, migraines quite often, and 2 or 3 days they're out.
Yeah, you can't work. You can't think.
No.
You can't work.
You can't open your eyes.
Yes.
Nausea. I mean, bright lights. Forget it. Wow.
So there's no reason for MS patients or migraine patients to suffer. And the only reason to suffer is if you didn't happen to see a qualified neurologist.
So how did they get a hold of you, Mr. Qualified Neurologist? Otherwise known as Dr. Costell.
Yes, ma'am. So we have offices in Delray Beach, on Linton Boulevard, and Boca Raton, in front of the Boca West Medical Center.
Oh, okay.
And you just have to call our office line. It's always available. 561-482-1027.
Great.
482-1027.
That's fabulous. Yes, please, by all means. I've got to tell you, they have studied all the various diseases when it comes to neurology, and can be there, can listen to you, can hold your hand as well, and guide you through, so that the ability of being able to connect with somebody, and especially emotionally, because this is such an emotional, it's almost like a tragedy sometimes when you have to deal with something like this, especially Alzheimer's and also, epilepsy too. But there are some medications from what you had said with epilepsy and or surgical. There's no surgical yet. Are there for dementia patients?
No, but for Parkinson's, yes.
Okay.
Yes.
Okay.
There's nothing surgical for Alzheimer's. Trying to think, in Australia, they are
Deep brain.
they're
I think,
experimenting.
they're experimenting.
They're experimenting in Australia right now with actually ultrasound, surgical ultrasound to break up these amyloid plaques. They're in initial trials right now. So there's something called ultrasound. It'd be similar to something we do for kidney stones in this country.
Right, right.
So for the disease Alzheimer's and actually Parkinson's, Dr. Ferreira may want to comment. There are some places globally that are looking into ultrasound guided therapy for both of those illnesses.
Wow.
So
That's great news.
So that's research, but in Parkinson's right now, for the certain patient, the right patient, you can have something called deep brain stimulation, where we stimulate specific parts of the deep brain that can help with a lot of your Parkinson's symptoms. There is a brand new technique that is approved in Europe, but not here in the U.S. yet, not for Parkinson's at least.
Okay.
It's called MRI guided, ultrasound focused, thalamotomy, and thalamotomy is a hard word. And where we do the same thing we do with the deep brain stimulator, but without surgery. They basically put a little ultrasound right here, and that ultrasound goes to the deep parts of the brain, and it makes a lesion, and the Parkinson's patient symptoms can get better.
Oh, that's incredible.
So that's Europe, not here in the U.S., hoping for soon.
Well, let me tell you, it will be coming. That's all I know. I can't thank the both of you enough for coming and being on the show, for giving us your knowledge, your education, letting us know some of the state-of-the-art technologies that are coming out, also the symptoms and prevention as well. So it has been an absolute pleasure to have the both of you on. And next week, we will be on again, you and your doctor, where we're teaching you how to live a longer and healthier life. And any doctors out there that would love to come on the show and also help educate our office or our audience, please give us a call at 888-717-7170. Ask for Maddie. Okay? Listen, we'll see you next week. Be safe and have a great week.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422, and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life. The opinions expressed on the preceding sponsored program